Today is a session on basics of echo where we are going to see the segmental approach. How do you proceed for any single echo, and the systematic approach will help you in the long run not to miss small things which you could otherwise overlook. So today's session is basically meant for the beginners, but it's important for all of you to carry on forever these few tips. As we can see here, consider heart as a house because every single block in the house is important. Similarly, in the heart, when you are trying to construct how the heart is made, every single step is important. So you have to go systematically, initially understanding the visceral situs, and then understanding the atrial situs, then understanding the ventricular looping, and finally going to the great arteries, and in between deciding the atrioventricular connection and the ventricular arterial connection. So the most important is how do we decide what is the situs? And it's important to understand that the situs is not decided just based on the sidedness. As we can see here that if we just say that it's a right atrium, left atrium based on its location, this is what is going to happen at the end of it. The anatomic landmarks inside the heart are basically defined by the septal surfaces. This is a very important message. Most of the landmarks are situated on the septal surfaces, and the decision whether which atria is the right atrium and which is the left atrium is based on the landmarks inside the atria and not just the position. And now here we can see, now I have to tell you that maybe there are 4 or 5 videos in the whole presentation which may not be playing on your side, though they are playing on my side. And in case you want a repetition of those videos, I will go to the main folder at the end of the session. So the first we will start with the understanding of the atrial situs. Now the visceral situs and the atrial situs usually go hand in hand, but there are some times where you may have discrepancies in the two. So first of all, we are going to start with the atrial situs. The atrial situs is the morphological. Right atrium and left atrium is decided based on the following points. When we use the word morphological, it means that right atrium in true sense and not the atria which is situated on the right side. So morphological right atrium is decided based on the presence of few things. The most important is the eustachian valve. The eustachian valve is the valve which guards the IVC. Now what in a situation where you have IVC interruption? Then we do not have this crucial feature. The second thing which can help us is the limbus of fossa ovalis. Limbus of fossa ovalis is situated in the central part of the interatrial septum. If you go embryologically, you know that the flap of foramen oval flaps into the left atrium. Simultaneously, there is sort of a convexity which protrudes into the right atrium, which is the limbus of fossa ovalis, and this is very much peculiar of right atrium. There is something else. If you can open up the IVC, as you can see in the first figure, the opening up of IVC can be done in the subcostal predominantly, and if the IVC is not interrupted and is draining into one atria, you could tell that this is right atrium. However, IVC drainage can be anomalous in situations of situs ambiguous. The second thing which is very important is the appendage of the right atrium. Sorry, this is right atrial appendage, and the right atrial appendage can be seen in the second figure. As you see the IVC and the SVC which opens up in the subcostal, next to the SVC on the right side you see this structure which gives a shape onto the right side of SVC, and this is the right atrial appendage. The right atrial appendage is commonly compared with a Snoopy's nose. It has a wide mouth connecting the right atrium, and this appendage is seen on the right side of the SVC in the subcostals, and sometimes you could figure out in the apical and parasternal. The last thing for the right atrium is the coronary sinus. Now as you can see here in the first figure, as you tilt posteriorly in the 4th chamber view, you see the coronary sinus which runs into the floor of the left atrium. So if it's a roofed coronary sinus, you can see this roof which is there near the floor of the LA, and the coronary sinus is not dilated. In the second figure, you can see that on color daughter, you can see the flow entering into the coronary sinus. This is so prominent because it has an additional drainage into the coronary sinus, which is the left superior vena cava. Now, in general, the coronary sinus opens up into the right atrium. So to summarize, we have few points which decide the morphological right atrium, including the IVC, the coronary sinus, and also the hepatic veins. As we can see here, the first and the second figure shows the hepatic veins draining into the right-sided atrium along with the IVC, which you could trace it from the subcostal. However, you can see in the second figure how interesting it is that the hepatic veins and the IVC are draining into the left-sided atrium. The left-sided atrium because this is a child with ambiguous situs. And hence it is very, very important that hepatic veins and IVC may drain anomalously, but the final determinant is going to be the fossa, limbus of fossa ovalis and the eustachian valve and the right atrial appendage. The right atrial appendage is actually based on the morphological characteristics, but there are ways on echo to determine where is the right atrial appendage. So now coming to the morphological left atrium, how do we decide which is left atrium? So as we saw, the flap of the foramen oval protrudes into the left atrium. This is even a very easy way in fetal life to decide which is the morphological left atrium, and that is the way to decide. In addition to that, in cases you cannot see the flap of foramen oval, you can use the pulmonary veins. The site where the pulmonary veins are draining, can we say this is left atrium? Not always, because you can have a total anomalous pulmonary venous drainage or sometimes partial anomalous pulmonary venous drainage. Then what do we do? So it's important to understand that if 3 or more than 3 pulmonary veins are draining through separate orifices, then it's likely to be morphological left atrium. The second thing which is important, like in the right atrium, is the left atrial appendage. Now very nicely in the first figure, you can appreciate the left atrial appendage here, which is compared to Snoopy's ears. You can see that it's a little more slender than the right atrium, and the mouth connecting with the left atrium is not as wide as the right atrial appendage. The second view shows the paroxysmal short axis, where you can see here the left atrial appendage is seen just next to the pulmonary veins. So the left atrial appendage is the way to determine the left atrial morphology. And in addition to that, you can take the flap of foramen oval and sometimes 3 or more pulmonary veins entering through separate orifices. Now once we have decided about the morphological right atrium and left atrium, you know that it is situs solutus, where the right atrium is to the right of left atrium. You proceed further and come down to the ventricular looping. We use the word looping for ventricles, and the decision which is which ventricle is based on the characteristics of the ventricle itself, and in addition to that, the AV valves. Remember, the AV valves always go hand in hand with the ventricles and not the atria. So first of all, we see in the first figure, we can see that this is an apical 4-chamber view. And how do we decide the right ventricle? You can see in the middle part of the interventricular septum, we have this prominent muscle bundle, which is the moderator band. Now the right ventricle has 4 muscle bundles, one of which is called the moderator band, which is situated on to the IVS around the mid-RV cavity. The presence of moderator band is seen in both the figures. Very nicely says that this ventricle is a right ventricle. In addition to that, can we see the septal attachment of the tricuspid valve? Now the tricuspid valve is septophilic. It likes the septum, and hence the septal tricuspid leaflet has attachment towards the interventricular septum. It hugs the interventricular septum. In addition to that, the right ventricle is more coarser. It has more coarse trabeculations. This is what defines the right ventricle. Now, how do we define the left ventricle? As we can see here, the left ventricle has smooth septal surface, unlike the right. The left ventricle has a smooth septal surface and the mitral valve is septophobic. How away from the interventricular septum it stays. It does not like the interventricular septum, so it does not come closer. Mitral valve stays away and has the insertion of the cordae to the free wall of LV, as we can see in this figure. In addition to that, you could also consider a few other things to decide about the AV valves. The tricuspid valve is a little inferior to the mitral valve. As we can see in this figure, the tricuspid and the mitral insertions are at separate levels. The tricuspid valve is closer to the apex compared to the mitral valve. Also that the tricuspid valve, if we see in short axis in the subcostal view, the tricuspid valve has 3 leaflets compared to the mitral valve, which has 2 leaflets. The mitral valve opening appears like a fish mouth, and both the papillary muscles, the caudal insertion is into 2 papillary muscles. As we can see here in short axis, the mitral valve is away from the septum and the tricuspid valve is hugging the septum. In any situation, if you see the mitral valve closer to the septum, then it is either a common AV valve or it is a straddling or an overriding mitral valve. A normal mitral valve does not touch the septum in a cross section. In addition to that, you can see that the left ventricle is typically slipper shaped compared to the right ventricle, which is more spherical. And if we go to the parasternal short axis, here this is how a typical fish mouth mitral valve appearance is seen. It has 2 leaflets and 2 papillary muscles. The 2 leaflets are the anterior mitral leaflet and the posterior mitral leaflet, and the 2 papillary muscles, the anterolateral and posteromedial papillary muscles, defines the mitral valve and hence the left ventricle, how smooth-walled it is. So this is how we define the right and the left morphological ventricles. Now, sometimes you can have ambiguous situations where you may not be able to define a ventricle, where it is a single ventricle, or sometimes the caudal attachments are not very clear, the morphology of the ventricle is not very clear, or it's a common AV valve which may not allow you to decide for the ventricular morphology. Sometimes it can happen like that, and you may tell it as an indeterminate morphology, but this is very rare. Now coming to the atrial situs. So once we have decided that the right atrium is which and the left atrium is which, we decide that the right atrium is situated on which side of the left atrium, and based on that we will name it as situs solitus. As you can see in this first figure, the right atrium is on the right. How did we decide? The IVC, the hepatic veins are entering into the right atrium, the limbus of fossa ovalis is into the right atrium, and the pulmonary veins into the roof of left atrium. This is situs solitus. And the situs inversus is in the second figure, where you can see the IVC and hepatic veins going to the left-sided atrium and the pulmonary veins going to the right-sided atrium, though in this figure we are not appreciating the appendages very clearly. So this is atrial, situs solitus, situs inversus, but sometimes you may not be able to differentiate the right and the left atrium. Then you will term this condition as situs ambiguous. In situs ambiguous, if both the atria are looking like morphological right atrium, it is named as right-sided isomerism, where asplenia is common, and if both the atria look like morphological left atrium, then polysplenia is a common association. How do we suspect situs ambiguous? We will see in further slides. Now coming down to the second understanding which we had is about the looping of the ventricles. It's called a bulboventricular looping based on its embryological origin. And here we can see that the right ventricle is to the right of left ventricle. Very nicely, the tricuspid valve is on the right, the mitral valve is on the left, the smooth walled ventricle is on the left, and This is the dextro loop or the D-looped ventricles. The D-looped ventricle is normal, and if you can see in the other figure, the morphological left ventricle is on the right of morphological right ventricle. So here we can see here the AV valve which is hugging the septum is on the left side. This is more coarser, and the ventricle which is on the right is more smooth walled. This is the left ventricle. So this is called levo loop or L-looped ventricles. So we can have a D-looped ventricle or we can have L-looped ventricle. Normally we have atrial situs solitus with a D-looped ventricle, that is atrioventricular concordance, and S and D. One most important point we have to understand is that the bulboventricular looping is regardless of the atrial situs. Embryologically, both are independent of each other, and you can have multiple permutation combinations between the atrial situs and the ventricular looping. Always remember the AV valves go with the ventricles. And second most important point is that the convexity of the aorta points towards the morphological right ventricle. This is in general and not 100%. So that we will see as we proceed further, but the convexity of the aorta can also be used to decide the morphology of the ventricle in difficult situations. Now coming down here, just an unusual scenario where you can see that the left AV valve is leaking, and you will feel like telling this is tricuspid regurgitation, mitral regurgitation, but it's not mitral regurgitation. You can typically see that the left-sided AV valve is below the right side, and you can here see the atrioventricular septum, which is the other way. The left-sided ventricle is more coarser, the right-sided is more smoother. This is L-looped ventricles, and hence here this is tricuspid regurgitation and not mitral regurgitation. So it's important to form the final understanding as TR and not MR just because it's a left-sided AV valve regurgitating. There is a rule of chirality which is called rule of handedness, where the right hand is compared with the morphological right ventricle. So this is how you will hold the right hand, where you have the thumb, the palm, and the fingers. So what happens is, if it is situs solitus with D-looped ventricles in a normal heart, the morphological right ventricle is right-handed. In the sense, you can put your hand and decide the inlet, cavity, and outlet, and this is how the right ventricle is situated inside, where the thumb is the tricuspid valve, the palm is the interventricular septum, and the fingers is the outflow tract. Whereas what happens in situs inversus? The situs inversus with L-looped ventricles, the morphological right ventricle is left-handed. This is an important understanding. This is called rule of handedness, where if it is situs inversus with L-looped, you put your left hand and understand how the morphological right ventricle is situated. And both are mirror images. This is for SD and this is for IL. I stands for inversus and L stands for L-looped ventricles. Now, the second most important understanding is the cardiac apex. Now, remember that the position of the cardiac apex to some extent is based on the looping of ventricles, because the apex of the heart pivots to the hemithorax opposite the bulboventricular looping. This is a little complex understanding which happens during embryology, and this means that when there is atrioventricular concordance, that means there is situs solitus with D-looped ventricles, the apex usually sits into the left hemithorax. This is because of the process which happens during the looping of ventricles. So the looping of ventricles to some extent is related to the position of the apex of the heart. So in general, it is levocardia. The position of the apex is to the left side in situs solitus with D-looped ventricles. Whereas in general, when it is inversus with L-looped ventricles, the apex of the heart is to the right hemithorax. That means dextrocardia. This is to some extent correlating and not always. Now, what happens when there is atrioventricular discordance? In the previous understanding, we had atrioventricular concordance. Now, what happens when there is discordance? Remember that when there is discordance, the apex sometimes gets confused and it sits in the midline, which is mesocardia. Here you can see the apex is in the midline. It's neither to the left nor to the right, and it's midline. This is mesocardia, and where you have atrioventricular discordance. That means if it's situs solitus, it is L-looped ventricles, or if it's inversus, it's D-looped ventricles. The atrioventricular discordance commonly goes with a mesocardic heart. Sometimes it's even more complex, that there is abnormal rotation of the cardiac apex. And when there is an abnormal rotation of the cardiac apex, you may neither have D-looped nor have L-looped ventricles. And in that situation, what happens is the ventricles are situated one over the other, as you can see in the first figure, which is called superior-inferior ventricles. And the interventricular septum is more horizontal than vertical. In this situation, you can see in the first figure, the right ventricle is superior to the left ventricle. I would say the usual dictum is the right ventricle being superior whenever you have superior-inferior ventricles. And sometimes you can have crisscross ventricles. The crisscross ventricles is something like this. What is a crisscross ventricle? When we use the word crisscross, we have to understand that it is the crisscross of the inlets. The inlets are crossing each other. So in the first figure you can see here, normally there is a harmony between the situs and the alignment. When we say that, I am trying to say that if it's situs solitus and D-looped ventricles, I would say it is atrioventricular concordance, usually. And if it is L-looped ventricle, it's atrioventricular discordance. But in crisscross heart, what happens? That even if it is L-looped ventricles with situs solitus, I still can have atrioventricular concordance because the hemodynamics is concordant. The right atrium is draining into right ventricle because the valve across it, the tricuspid valve, is diverting the flow to the correct ventricle morphologically, but situated in the other direction. So this is what is crisscross inlets, where you do not have harmony between the situs and the alignment. So this is what is crisscross ventricles. So superior-inferior ventricles, crisscross ventricles are exceptions and they are rare. Now coming down to the third brick, which is the great arteries. Now we need to understand that great artery connections are not the same as the relationship between the great arteries. There is something like relationship between the aorta and the pulmonary artery, and there is something which is deciding the ventriculo-arterial connection. Both do not always go hand in hand. For example, you can have a transposition, that means the aorta is coming from the morphological right ventricle, but the relationship may not always be in a particular way. So when we talk about great artery connections, we are talking about the ventriculo-arterial connection. As we can see in this figure, the parasternal long axis, the LV is giving rise to the aorta and the PA both. However, the aorta and the mitral valve are far away from each other. That means they are having a conus, and hence we will particularly say that the PA is from LV and not the aorta. So this is the transposition of great arteries, whereas what happens in connection we will talk later. Now how do we decide which artery is which? The aorta and the pulmonary artery are based on the branching pattern. The pulmonary artery branches very much inside the chest, whereas the aorta gives rise to arch vessels a little above in the neck. So branching pattern of the PA, as you can see here, branching into the chest defines this artery as the pulmonary artery, whereas the coronaries define the other vessel as the aorta. You can see here the coronary arteries are seen from the aorta, and this is the bigger one is the aorta, the smaller one is the pulmonary artery. However, we have exceptions to this. Always you do not have right and left pulmonary artery coming from the main pulmonary artery, and always you do not have all the coronaries coming from the aorta. And you know the exceptions where you can have anomalous left or right coronary arteries, or situations like hemitruncus, where one of the pulmonary artery is coming from the aorta. So there are few exceptions, but in general, you could use the branching pattern and the coronaries to define the great vessels. Now coming down to the second component, which is the relationship of great vessels. Now normally here we can see in parasternal short axis. Understand, all images can tell you the relationship, but the final decision you will take only on parasternal short axis when you cut the great vessels at the level of semilunar valves and decide how they are related to each other. Now here we can see in the first figure, the pulmonary artery is left and anterior and the aorta is right and posterior. This is normally related great vessels. Now in the second figure you can see here that the aorta is right and posterior, the left and posterior, and the pulmonary artery is right and anterior, and this is defined as I malpost. I malpost is normal for the inversus heart. Aorta is posterior but to the left, PA is anterior but to the right. D malpost means the aorta is to the right and anterior and PA is left and posterior. L malpost means the aorta is left and anterior and PA is right and posterior. So you have multiple possibilities where you can have D, S, L and I, but sometimes you can have a relationship as side by side or intero-posterior. Now, so with this connection, we have understood the atrial situs, the ventricular looping and the great arterial relationship and connections. Now, sometimes you can have an abnormal ventricular arterial connection in terms of a double outlet, individual ventricle. We know right ventricle is far more commoner than the left, or it can be a single outlet where you will have to define it separately like a truncus, aortic or pulmonary atrasia. So as you can see here in this figure, you have a superior inferior ventricle, the aorta is coming from the right ventricle and PA is coming from the left ventricle. There is a rule of handedness which we saw, and then the second rule is rule of 50%. It says that the cardiac chamber which receives 50% or more of an inlet is defined as a ventricle. So now it says that you do not need an outlet. It needs 50% or more of an inlet. What happens if it's tricuspid atrasia? It just needs the fibrous ring of the AV valve, so it is still a ventricle. It does not have to be a patent inlet. So this is what defines a ventricle. And 50% or more of a great artery coming from a chamber, then you would tell that that great artery belongs to that chamber. And that's how we would define a double outlet ventricle, either right or left. So this is a rule of 50%. Now, based on the understanding what is defining a ventricle, let us say when we see a small chamber, whether is it a ventricle or not. So this says, some people would say that instead of taking the 50% inlet rule, you would take that a trabeculated portion of a chamber makes it as a ventricle. So when a chamber receives less than 50% of an inlet, what do we call it as? Then it's called as a rudimentary ventricle or the rudimentary chamber. So though it has a trabeculated part, it receives less than 50% of the inlet. Now when it is a rudimentary ventricle, whether it has an outlet or not defines it as an outlet chamber or a trabecular pouch. If 50% or more of an outlet is there, that means a great artery is there, you will call it as an outlet chamber. And if it's less than 50%, you call it as a trabecular pouch. Now, how do we decide the abdominal situs? As we said, the abdominal situs does not 100% correlate with the atrial situs. So the abdominal situs here, you can see in the first figure, The liver and the left-sided vessel which is seen is the aorta and the right is the IVC. How do we define the IVC? Thin-walled venous pulsations is IVC. Thick-walled arterial pulsations is aorta. So the aorta being to the left and IVC being to the right of spine is abdominal situs solitus. In addition to that, you have the liver on the right and the stomach bubble on the left. Now see the second figure where you have the IVC to the left along with the liver and the aorta to the right, and this is abdominal situs inversus. Here you can see double check in the sagittal view where the IVC is to the right and the aorta is to the left. So you keep sweeping in the sagittal view and double check the correlationship between the IVC and the aorta. Now, if the liver and the stomach are midline or they are the other way with IVC and aorta to the same side of midline, it is an ambiguous situs. Anytime IVC and aorta to the same side of midline, either right or left, defines it as ambiguous situs. Now, right-sided isomerism means both the sides are like right atrium. What is the typical characteristic feature is that both warns the systemic veins. That means bilateral SVC is very common and none side warns the pulmonary veins. That means a TAPVC is common. Right-sided isomerism commonly has also a single ventricle, a common AV valve, pulmonary atresia, double outlet right ventricle, etc. But the typical feature is bilateral SVC and TAPVC. Whereas if you go to the left-sided isomerism, remember that both warns the pulmonary veins. As you can see in this figure, the right-sided veins would enter into the right atrium and the left-sided veins would enter into the left atrium. And none wants the systemic vein. That means IVC interruption is more common. Along with that, you can have intracardiac defects like VSD, double outlet right ventricle, etc. So this is about the isomerism. When do you suspect right and left-sided isomerism? Now I'm going to go through few next 4 or 5 slides for dextrocardia. Now, dextrocardia is defined as a situation where you have your base apex axis on the right side. So the base apex axis is from the left shoulder to the right hip. And there are 3 types of dextrocardia. One is the middle one, which is the mirror image dextrocardia, which is very typical of the usual dextrocardia where the situs is inversus and the heart is to the right side of the chest. The other one is dextroposition, which as pediatricians we see commonly when we have situations where the heart is pushed to the right side of the chest like hernia diaphragmatic. And the third variety is dextroversion. Dextroversion is a situation where you have problems with the rotational axis across the base apex of the heart. Where heart is pushed to the right side of the chest, the apex is to the right, but the left ventricle is anterior, not the right ventricle. That means there is something to do with the rotational axis of the heart. Can we differentiate all these 3 on echo? Yes. So we can differentiate all these 3 on echo from all the views, and here this is the understanding. Now basically we understand that dextrocardia mirror image is situs inversus. So there is no confusion in this. Dextrocardia mirror image has situs inversus, whereas dextroposition and dextroversion is situs solitus. Dextroposition is where heart is pushed. So the heart is on the right parasternal area, but not significantly on the right side. Whereas the axis of the heart is still to the left. Whereas in dextroversion, the axis of the heart is to the right. And the images which are taken for dextroposition are exactly like a normal levocardia heart, but with a probe on the right side. Whereas on dextroversion and mirror image dextrocardia, there is a little difference because your base apex axis is changed. Now we will see how do we take images for a mirror image dextrocardia. The mirror image dextrocardia, your subcostals, the cursor is exactly similar. The cursor is towards the left side of the chest, and your subcostals, sagittal and coronal is taken like in a normal heart. However, you will see your apex towards the left and not towards the right and not towards the left. So this is how an image of a mirror image dextrocardia will look, where there is situs inversus. In this child, there is the looping of the ventricle is different, but the looping has nothing to do with the mirror image dextrocardia and situs inversus understanding. So the subcostal is in a similar way. When we go to the apical, the cursor is pointing like a normal levocardia heart, but you put the probe towards the right side of the chest. And you see an image like this where you have situs inversus. The pulmonary veins are seen here, the coronary sinus is seen here, and it's L-looped ventricles and I malposed great vessels. So in short, you would term this heart as dextrocardia ILI. And your cursor is like this towards the right side of the chest. Coming to the parasternal long axis is the place where there is a little difference. And you can see here the long axis is made like this, from the left shoulder to the right hip, which is across the axis of the heart. This is for the mirror image dextrocardia and also for dextroversion dextrocardia. So it is exactly 90 degrees compared to a normal heart in levocardia. So parasternal long axis, if you put the cursor like this, do not change the buttons anytime. The upside down, the left right button, do not change. You will see a heart like a normal heart. So if you see this image, you cannot say whether this is dextrocardia, mirror image or levocardia. But based on how you have put your position of the probe and the cursor, you know that this is mirror image dextrocardia. And the short axis, you rotate another 90 degrees from there. That means your cursor is towards the left hip and your probe is across the left hip to the right shoulder, and you will get an image of a short axis. And here peculiarly you can see the pulmonary artery is right and anterior, the aorta is left and posterior. This is I malpost, which is normal for a mirror image situs inversus heart. So this is what is the short axis for a mirror image dextrocardia. For dextroversion, somehow it comes in between the long and the short axis here. So this is how you would see the dextrocardia images. And in dextroposition, you can see here the subcostal, the apical. The cursor is towards the left, but the probe is more closer to the chest. And the long and the short axis is like a normal heart, but on the sternum or a little on the right side. A little mention here, juxtaposition. This is the last slide for today's presentation. And juxtaposition of the appendage has some significance in terms of the further management for any child. And the juxtaposition is very common with hearts with transposition of great arteries. And we can see here in this figure that the left juxtaposition of the right atrial appendage is there. Now, how do you see that? You see because first you open up the atria, and then you see the interatrial septum, then you see the juxtaposed appendage, and then you see the great vessels. So the appendage actually is sandwiched between the great artery and the interatrial septum. And the right appendage goes to the left side, so it is the term used as left juxtaposition of the right atrial appendage. Thank you, and any questions are welcomed.